key takeaways and things I wish I would have known before an audition rotation. This presentation was largely motivated by I just finished an audition rotation for fellowship. And so all of these principles that I'm going to be talking about today were all things that I basically had to redo as now a fourth-year orthopedic surgery resident. And so I thought it would be a helpful reminder about what are things that we're going to be looking for when students are coming in to audition with us. And ultimately, everything through this presentation, my goal is to tell you the things I wish someone would have told me. And I will leave some time at the end for some questions and answers. And keep in mind, there is so much content that I'm not going to be able to cover today. So my goal is to hit the heavy hitters, the questions and topics that are most commonly asked on different presentations when students come. So for those of you who don't know me, my name is Janae Rasmussen. I am a fourth-year orthopedic surgery resident at the Valley Consortium for Medical Education, and then I am the OrthoLink Scholars Resident Physician Research Chair. So the outline for today, first we're going to talk about how do you maximize your rotation. I'm going to be talking I'm going to talk about fixation terms. We're going to review bone healing principles, and then what students often make when asked to read an X-ray and things like fracture conference. I'm also going to be talking about common classifications and related topics. And then finally, I'm going to talk about some resources that I recommend using as a med student, including a lot of them that I still use as a resident, and then overall summary. So to start off, we're going to talk about how to maximize your audition rotation. So the purpose of an audition, also known as a sub-I or a sub-internship, is it's really an opportunity for you to provide insight to a program about your personality, about your motivations for applying for orthopedic surgery, and then your interest in a program. This is your chance to showcase your soft skills. So what I mean by that is your ability to work on a team, your ability to be able to navigate complex or challenging scenarios. How do you interact with attendings? How do you interact with patients? All of those are difficult to convey sometimes on like a CV or even in like a personal statement. So this is the program's opportunity to get to know who you are and how you interact within their program's culture. This is also the opportunity for them to see, are you able to keep up with the rest of the medical students on a rotation? Are you able to meet the academic expectations? And one of the most important points is, do you work well on a team? I'm going to talk about some of the common mistakes that I see students make. And one of the most notable mistakes that I see are students that do not work well with other students. They don't work well with the residents that they're working with. And ultimately, that typically results in them not getting interviews. So the main things that programs are looking for is one, is there a commitment to the specialty? Particularly for orthopedic surgery, they want to make sure that if you're going to orthopedics, that you're in it for the right reasons and that you have a really good grasp of what the fundamentals of orthopedics are and why ultimately you should be pursuing that subspecialty. Another important aspect is, are you someone that's teachable? Do you have self-awareness? Are you someone who cooperates well on a team? Are you someone that has good communication skills? Are you someone that works well within the program's culture and ultimately has cultural competence, meaning that you can work with patients that are underrepresented minorities, or you can work with patients that are maybe from more affluent communities? But the point being is that you're able to navigate all of those different spaces in a professional manner. So there's a lot of common mistakes that I see students make on auditions, and these are some of the heavy hitters. One of the most important ones is not preparing. When you are being asked questions, most commonly, those questions are going to be related to anatomy questions. So that is where your focus should be on. It should be on basics. So for example, on my audition rotation for fellowship, there was a medical student that was in the room and we were doing an ankle procedure. And so the questions coming from the attending were, what are the compartments of the leg? And then after asking those questions, it was, what are the innervations, of the different muscles in the leg? And those are basic anatomy questions that are, the 101, what you should be expecting to be asked. Now, you might have some attendings that are going to ask you, or even residents that might ask you way more complex questions, but ultimately, you are not expected to know approaches to different surgeries. You're not expected to know a lot of the complex classifications. If you know them, great. It's certainly bonus points. But what stands out is oftentimes when students know the basics anatomy, but then they show teachability to show interest in learning other orthopedic concepts. You will be thrown into situations on an audition where you might not have time to prepare for a case. Maybe you're in clinic all day with another resident and now you were placed on call and you didn't know what call cases were coming in. And so sometimes you're going to be asked questions or put into scenarios where you don't know the answer. In those instances, which will happen, which is important is that you demonstrate teachability. You demonstrate the ability to come back the next day or next time you're with that attending or that resident, say, hey, I read more about this, or I wanted to clarify this. And so another common mistake that I see is medical students that make the intern, the resident, or other medical students look bad. It is unfortunately something that can really deter your ability to get an interview. And some examples of this. So for example, if you see some, patient that needs like a wound vac change or needs some sort of wound, care, that might be something where maybe you get a group text with the other medical students and you showcase to the intern like, hey, I'll help coordinate with the, my co-medical students and we'll figure out how to do dressing changes and send you a photo after. And it's a way that you can help take off some of that burden from the intern who's responsible for many things, while also showing that you're, working with the medical student. Another, down to the emergency room and do a reduction. Texting with your medical students to say, okay, well, I'm going to be with this resident. Is someone covering the call shift? And really maximizing your ability to work on that team and really help make things easier for the intern, make it easier for the residents. Another common mistake, unfortunately, is medical students that are acting unprofessional. We had a medical student this past year that actually made fun of one of my co-residents who was on crutches. I could not believe it, but that actually happened. Another common thing that I have seen are medical students that have argued with residents, that have argued with attendings. It still blows my mind when I see these things happen. And the reason why I want to emphasize this to you is because it does unfortunately happen. We have medical students that rotate at my program, and I've seen when I was an auditioning medical student that come from phenomenal institutions on paper, and oftentimes those students act very unprofessionally or demonstrate inability to work on a team. And with that, another common thing that I see is just arrogance. You are not going to know all the answers. I'm not going to know all the answers. The attending's not going to know all the answers. If you come in and act like I already know how to do this procedure, that is not going to go over well. A common example that I've encountered is, for example, when I ask the medical student, hey, do you want to come help me do this reduction or put on a splint? And the medical student comes in and say, oh, I've already done a bunch of these at the other rotation. I can do it, no problem. And you're trying to convey some sort of confidence, but it's way better to err on the side of caution. It's much better to say, I'm really eager to learn from you. Here's my basic understanding, or here are the principles that I know. What can I help get you ready to get things set up? Or do you want, this type of plaster for your sugar tong splint? So there's ways to communicate that you're paying attention, that you're actively involved without coming across as you're a know-it-all, or you're coming across as someone who thinks that they're better than the resident. Another critical issue are medical students that are kind of antisocial. They have difficulty with soft skills. They have difficulty interacting with other medical students. Now, you don't have to be super outgoing, but there's a big difference between being the medical student that sits in the corner and doesn't say anything and everyone forgets that they exist, compared to being the medical student that you might be a little bit less extroverted, but you're still actively engaged. You still talk one-on-one with your residents, you engage well with your medical students. And so it's a hard balancing act. And that's why they call it soft skills, because it's not a black and white, here's good, here's bad. It's oftentimes, can you read a room? Something else that I've seen on audition rotations are students that leave early. I remember being in a distal femoral replacement, also known as a DFR, and this is not a common surgery that's done. And the medical student, it was 7 p.m., they said, hey, I'm going to have the other student tag me out because I'm not on call tonight. And I told the student, well, this is a really good case. Even though you're not on call, I recommend you stay with us. And they said, nope, I'm not on call. And they scrubbed out and they left the room. And that student did not get an interview with us because of multiple things that they did that demonstrated that they weren't a good fit for our program's culture. But my point being is this is a learning opportunity. You are going to be stressed. You're going to be working very hard. And so it's really important that you maximize that. I always tried on my audition rotations to make sure that I was popping into rooms, checking in if other medical students needed help, checking if residents needed help. And this is where, if you start like a group chat with other medical students through texting or whatever app you want to use, that can be really helpful. What I often did was got like the intern to be on a group chat with the other medical students. And then that way the intern was always aware and could text us like, hey, I need help with getting this splint cart set up, or I need help with doing a dressing change for this room. And it made it so that you're sort of demonstrating leadership ability, but you're also demonstrating that you're actively engaged in what you're being asked to do. Rotations are challenging. You are going to be exhausted. On my most recent audition for fellowship, we spent all day in the operating room. It was about 10 p.m. Hadn't, had lunch, had dinner or anything, but, we added on another trauma case and it was like, great, let's keep going. Don't complain. Make sure that you're showing that positivity, even when your body is telling you, oh my gosh, I'm so exhausted. You haven't slept well the night before. Everyone is watching you. Do everything in your power to maintain that professionalism, maintain that enthusiasm. Another important aspect is when you don't ask for help or feedback, which ties into when I see students that are very arrogant that think, oh, because I auditioned at this big name program or because I've already done this, that all of a sudden they think that they're better than other students, or sometimes they act like they're better than the residents. You are there to learn. You are there to demonstrate that you are teachable, that you are great working on a team. And one of the things that I always tell students is imagine it's 2 in the morning. Are you someone that the resident's going to want to call in to say, you know what, they're actually helpful to come help me manage this trauma? When I'm managing home call, there's a lot of medical students, I don't even bother calling them because I'm like, it's not actually going to be that useful and it's more work for me. So think about that. Are you going to be the student that's going to actually be helpful? And are you going to be someone that is going to make the resident's life easier? And then one of the most common things I see are medical students, they stand on the back of the room and they don't help out with turning over rooms. They don't help clean up trash. They don't talk with the OR team. They walk into a room and they don't ask the, circulating nurse, hey, can I write my name on the board? By the way, this is my name. This is my role. How can I help you? Those are very simple things that can make you stand out and showcase that you know that you're not above anyone else. And even as a resident, I help with turning over the rooms. Just because now you become a resident or you become an attending does not make you better than your OR nurses or anyone else that you're working with. So another thing that you will expect on audition rotations is typically there'll be an end of rotation presentation. Not all programs do this. My program certainly does, and all of the places I auditioned at did this. And essentially, it's a way for you to do a 5 to 10-minute presentation to demonstrate your presentation skills, and it also helps you stand out as being more memorable. And so what you want to do is you want to pick a very specific focused topic and think about something that's more unique or memorable. A common mistake I see students do is they'll say, I'm going to present about ACL injuries. That is way too big of a topic to possibly cover in 5 to 10 minutes. So think about something way more specific if you want to cover ACLs, for example. My presentation that I did on all my auditions, and I just slightly modified it depending on which program I was at, was I talked about pain control and orthopedic trauma. And I kept it very bare bones. I talked about some of the different opioids. I talked about the use of things like vitamin C to help with pain control. And I tried to keep it very straightforward and generalized. And one of the benefits of me picking that topic was it was very unique. Not a lot of other students pick that. And it was something I could basically use at all my different auditions without having to completely redo my ultimate presentation. And when it comes to when you actually give the presentation, do not read off the slides. I can't tell you how many students come in and they sit there and they read off the slides. They have all these words and it just demonstrates that they don't have a lot of comfort with public speaking. And so making sure you're being professional, sticking to the time limit, not reading off slides, making sure that you're including literature. I would often include like screenshots of some of the articles that I would cite within my presentation and trying to just keep things so that it was very specific, focused, and to the point. You don't have to do it based on a case you saw. However, if you had, let's say, a really memorable case, it could be certainly beneficial for you to present on that case, but you don't have to do that. One of the things that I did was when I first started my rotation on week 1, I asked the chiefs that were coordinating if I could present, for example, on week 3 or at the beginning of week 4, and showing that initiative to say, I'm ready to go, I'm happy to present before my last day, and making sure that you ask for feedback on your topic. Another important consideration is how can you keep costs down? So when it comes to audition rotations, I personally stayed with residents. The way that I did that was as soon as I got an audition rotation confirmed, I would reach out to the program coordinator, and the program coordinator would help connect me with different residents. So that's something that I would highly recommend you do. They also have different websites such as Furnish Finder, Rotating Room, and those are different ways that you can help make things a lot cheaper. One of the things to keep in mind that if you do stay with residents, remember you are always being watched. So I really enjoyed staying with residents because for me, it was a way to showcase my personality. It was a way to help them get to know me better. However, I have heard many horror stories from some of my co-residents that have had medical students that were didn't keep things clean, that were unprofessional. And so it's just something to be mindful of is if you are going to be staying with the resident, remember, you are always being watched. Always make sure that you are acting in an appropriate manner. All right, so I'm going to talk about just some common general terms just to start off. So you'll often hear residents or attendings throughout the word ORIF or ORIF, which stands for Open Reduction Internal Fixation. This is a big umbrella term for saying we're going to be making some sort of opening, meaning an incision. We're going to be reducing, meaning putting the fractures or bones back together, and then providing internal fixation, meaning we're putting some hardware in inside the body. And there's going to be lots of different ways that this could be termed depending on the consent. For example, some attendings might say like operative fixation with, hemiarthroplasty or with internal fixation. But the point being is you'll likely hear this term ORIF, and that's just this big umbrella term for saying we're going to be putting hardware in. Another common term is X-fix, meaning external fixation. There are a lot of different types of external fixation devices. You have Ilizarov frames, etc. But most of the time, what you'll likely see is in the context of like a trauma. And so this is often a temporizing measure where essentially you're have a bunch of like soft tissue swelling, or it's not safe to put in a bunch of different hardware inside the skin. And so you might put on an external fixator. And then another common term is CRPP, also known as close reduction and percutaneous pinning. This is oftentimes used, for example, in a lot of pediatric fractures. However, there are some adult fractures where this can be very useful as well. And this is where you literally take the pin and you're putting it in through the skin. And it's a way that you can help with manipulating fractures and holding things in place, and then you can pull things out in clinic. So I'm going to be talking about some basic bone healing principles. There are a lot more details than what I'm going to have on these slides, but these are the bare minimum of what you should come into your audition rotation with understanding. So there's two basic types of bone healing. The first is primary bone healing, and this is what we call absolute stability, meaning that this is where you're essentially taking the broken bones and you're putting them basically right into the proper position, and you don't want a lot of motion. And so this is where you have what we call minimal strain, ideally strain under 2%. And what this means is that you're not going to get a lot of callus formation. What a callus is this is essentially where if you have a lot of comminution, meaning big fragments within the bone, or you have a lot of, space, that callus can basically come in and it has all these healing factors that starts from a hematoma that comes in, and then it starts with being able to form new bone down the line. With primary bone healing, we don't get that. We basically just get the bone and we get that direct healing. And so you'll see the fracture line basically start to disappear with time. And so a good example of this is compression plating, which I have on this slide over here to the right. Sometimes you'll see this in concepts such as with this, like like a distal radius fracture or like a bone form. Cases with what we call secondary bone healing. To that, this is nuded pieces, or you're using nail where you're not getting the fracture to be perfectly allowing have strain between 2 to 10%. And this is where we get callus formation. And when we get that callus formation, this allows for remodeling. And this is what allows for the bone to ultimately heal with time. And so in the image on the bottom here, you can see where you start off, where you get this big callus formation, or you get this hematoma, which ultimately results in getting this callus formation. And so a lot of things can cause this: casting, intramedullary nails, doing an external fixator if you use that for your definitive fixation. So now we're going to talk about the basics of how to read an X-ray. And I feel like this is one of the most intimidating moments on audition rotation, especially when you're being asked to read an X-ray in front of a whole crowd of residents or attendings. And it can be very nerve-wracking. Even as a resident, sometimes I get a little nervous with reading an X-ray. So I want to try and make things as simple as possible. So this is kind of the stepwise guide. The first thing is you want to note the number of views and what the views are describing. Then you want to know, what is the body part? You want to note, is it a skeletally immature, meaning a kid, meaning that the open physes or growth plates, or is it a mature patient? And then ultimately, what is being demonstrated? Is there a bunch of fragments? Is there segmental fracture? Is there displacement, angulation? Do you see any visible air, meaning indicating that there's an open fracture? Do you see a lot of significant soft tissue swelling? And the list can go on and on about all these little nuances. But the point being is that if you can come in and you can note the number of views and the views describing the body part, are they skeletally mature versus immature, and what is being demonstrated in a concise way, that can really help you stand out. One of the common mistakes that I see is that students will start reading an X-ray and they kind of get like word salad, like they just start talking and talking and talking, and then they start throwing in, oh, and it's this classification, and sometimes just take a breath, because what you want to do is you want to read the X-ray, and even if you know the classification, don't tell them that. Let them ask you, because you will look way more impressive if they ask you about a tibial plateau fracture and you read it correctly, and then they say, well, what's the Schatzker classification? And then you say that. That's going to look way better versus you just throw out a whole bunch of words and you speed through it, and then you feel completely overwhelmed in that moment. So here's an example on the right here. And I have it written out here, kind of a way that you could describe this. So this is a 2-view AP and lateral of the distal tibia and ankle in a skeletally mature individual, demonstrating an oblique fracture to the distal tibia shaft and distal fibula with varus angulation and displacement in procurvatum. And I'm going to talk about some of those terms coming up. But again, this is a way for you to help framework reading an X-ray, and it's better to be short and sweet and potentially leave out things than for you to just continue to talk and talk, and now you're 2 minutes in and everyone's just looking at you and they're wondering where this is going. So I'm going to talk about some of the different terminology that we often use when we are describing X-rays. So one of the most common ones that we describe is it varus or valgus? And oftentimes when we're using this, we're describing, for example, in this image, like the knee, but oftentimes it can be, where a fracture is displacing. And so in this example, what we can see here is that on the medial side, we can see laterals here, we can see the fibula here. On the medial side, we see that there's less joint space and more opening on the lateral side. So this is an example of a varus knee. And in this image here, this is from the hip and knee book, which I'll talk about at the end. This is a great resource that I still use as a resident, where they talk about joint arthroplasty. But this is an example of how we might talk about things like a valgus or a varus knee. And it's really just understanding, where is midline of your joint, and do you see that there's angulation that's going towards the midline or away from midline? So speaking of angulation, this is also something where you might have it described where you'll see like it's varus angulation or valgus angulation. And it's the same principle of understanding where things are going. So for example, in this image here on the right, and there's a lot of other potential descriptions. So like I mentioned, a fracture might be a transverse fracture. You might see things like an oblique fracture, noting, is it displaced, versus in this image here, we see that it's transverse, it's non-displaced. Do you have a green stick fracture? This is most commonly encountered in your pediatric population. And then with your comminuted fracture, this is oftentimes where you see a lot of pieces displacement. And so like in the image here, we can see that there is displacement in this periprosthetic fracture. So when it comes to procurvatum or recurvatum is where essentially the distal aspect is pointing forward. So in this image here, you can see that it looks like the knee is up here, but it basically almost looks like it's kind of like bent backwards versus in procurvatum, you can see that this distal aspect is pointed backward. So in this image here, we can see that this is in recurvatum. And then when it comes to when we describe like the apex of the fracture, this is listed based on the proximal fragment. So distal meaning further out, proximal being closer to the body. And so in this example here, I really like this image. This is actually the resource at the end of the fracture here is dorsally displaced, meaning it's going towards the back of the hand. And this means that the fracture apex is going volar. So this is apex anterior or apex volar angulation. And so what can be very helpful is when you're reading an x-ray, if you're unsure, take a breath and make sure that you understand what is medial, what is lateral, what is volar, what is dorsal. And remember that with any x-ray, one view we always say is no view. You always want multiple views. So you might be in the scenario where they only give you one view. And especially in those, it's better to say less than to say more because you only have one view. So now I'm going to highlight just some of the key classifications and topics that you might be asked about. A lot of these classifications, these are things that as a resident we're expected to know, but not so much as a medical student. Again, as a medical student, the expectation is that you are focused on anatomy. Now, if you can come in and you can have some of these memorized and know some of these, great. You're only going to get bonus points for that. But it's much better to make sure that you focus on the anatomy as opposed to you knowing all the classifications but you aren't comfortable with the anatomy. That's going to look way worse compared to if you're strong with anatomy and you show this interest and engagement in understanding these classifications. So one of the first classifications is called the Pipkin classification, and we use this for the femoral head. And so on this image here on the left, this is depicting the different types. So in type 1, we have fracture of the femoral head, which is caudal, meaning below the fovea capitis. Type 2 is where you have fracture of the femoral head that's cephalad, meaning above, cephalad thinking head to the fovea capitis. 3 means that you not only have a femoral head fracture, but you also have a femoral neck fracture. And then type 4 is where you not only have a femoral head fracture, but you also have a fracture to the acetabulum. Most commonly, you'll see things like this in like a posterior hip dislocation. And the reason why this matters is because this ultimately will change whether or not the patient needs surgery or what type of operative management. There's a lot of literature, for example, where if you have a fracture that's below the fovea capitis, sometimes you can manage that non-operatively, presuming that there's no fragments that are stuck in the joint space or causing joint incongruence. Versus if you have a patient that has one that is affecting the weight-bearing surface, or a patient that also has a femoral neck fracture, even if they have a fragment that's below the fovea capitis, but they have the concomitant femoral neck fracture, that's one where they're going to need surgery. And so really the key takeaway with this classification is that it is useful for us in being able to judge what patients need surgery, and even more so, what kind of fixation would be useful, and also what type of approach. So for example, with femoral head fractures, a lot of surgeons, if they don't have an acetabulum fracture posteriorly, they might do like an anterior approach so that they can directly get to the anterior surface of the femoral head. But now if you have a posterior acetabulum fracture, such as a posterior wall, that's likely going to change the type of approach, or maybe you have to do dual approaches. So that's why this classification is important. Another common classification has to do with the femoral neck. This is called the Powell classification. And what this is looking at is this is basically looking at the angulation of where that femoral neck fracture is. And this is very important for considering operative management and the likelihood that the patient might go on to things like non-union or have other issues. So for your type 1s, this is going to be where the neck angle is under 30 degrees. Versus type 2 is it's going to be between 30 and 50 degrees. And then type 3 is where it's going to be greater than 50 degrees. Those that have more vertical femoral neck fractures typically have more shearing forces, meaning that those are going to be the ones that are going to be more likely to be unstable, have a higher rate of going on to things like non-union. So that's why this is very important. This also can help impact what type of implants that we're considering using. For example, we have some internal fixation devices that basically can provide compression. We have some that we call basically cephalomedullary nails that can basically help give us fixation through the femoral neck and then also give us more fixation distally versus ones that we call like the femoral neck system, where we basically have a plate that comes on here and screws that go across. So the point being is that when we look at the femoral neck, it's not just about do they have a femoral neck fracture, but we also have to consider what is the angulation and then thinking about things such as the age of the patient. Is this a patient where it's non-displaced, they're a young patient? In that scenario, we're likely going to be thinking about operative fixation. Versus if this is displaced and they're a geriatric patient, we're far more likely to think about things like a total hip arthroplasty or a hemiarthroplasty, meaning a partial hip replacement. So now I would say this is probably the most commonly asked question with fracture conference because femoral neck fractures are so commonly seen, which has to do with the Garden classification. And this is where we're looking at whether or not there's displacement of the femoral neck fracture. So in Garden type 1, we can see that it's an incomplete fracture of the femoral neck. And so with this, we oftentimes call it a valgus impacted. And the reason why that's important is because you will sometimes see patients that actually had a valgus impacted femoral neck fracture and they're seen 3 weeks out and it's basically already started to heal and they can walk on it, it's sore, and those might be ones you can treat non-operatively. And so that's where that can be very important versus one like a Garden stage type 2, where now it's a complete fracture, but it's undisplaced versus type 3, where it's a complete fracture, but there is some displacement. Those are ones that you absolutely will need to make sure that you have some sort of fixation and reduction with. And then type 4 is where you see one that's completely displaced. And typically in your Gardens type 4, this is going to be like in your elderly patients, because they get such poor blood supply and can get things like avascular necrosis, we're typically going to be doing things such as a total hip replacement or hemiarthroplasty, depending on the age and activity levels of the patient. In a really young patient, like a 36-year-old male in a motorcycle accident, he has a Garden 4, oftentimes most orthopedic surgeons are still going to try open reduction internal fixation. They're still going to try to fix the fracture, knowing and talking with the patient about the risk of getting things like avascular necrosis. A large part of that is because we want to try and avoid things like arthroplasty unless, the initial intervention fails. But these are the ones that tend to have the worst prognosis, particularly in younger individuals. Another common fracture that you'll see are intertrochanteric fractures. And there are different classifications, but I think the most important thing to focus on is determining what's stable versus unstable as an intertrochanteric fracture. And the reason why we call it intertrochanteric is because we can see the greater trochanter here, lesser trochanter here, and basically there'll be some sort of fracture line that goes from the lesser to the greater. Now, it's not always directly going across. You might see ones that have what we call like subtrochanteric extension. You might see ones that almost look a little bit more basicervical, meaning that they kind of come from the greater troch and they basically kind of come across over to above the lesser trochanter. But the point being is that these are ones where if you have one that is unstable, which I'll talk about what those characteristics are, those are going to be ones that a lot of the typical types of implants, such as a DHS screw, will likely fail because you can't provide direct compression through them. And so these are often ones where you'll see them using things like a cephalomedullary nail. For like synthes, we call it like a TFN or trochanteric fixation nail. What matters in those scenarios is that we're basically putting some sort of fixation through into the femoral head and neck region, and then we're putting fixation distally. So those that are unstable, these include subtrochanteric extension, and that's what you can see and depict in this image here, where we can see that the fracture line basically goes below the lesser trochanter, and typically if it's within that region of 5 centimeters below the lesser trochanter, we call that subtrochanteric extension. Another one is what we call reverse obliquity. And so that's one where you can see here in this image. And what happens here is that if you provide a compressive force here, that's often ones where it won't actually stay stable. And so you have to consider different types of fixation. Another one is posterior medial comminution, and that's what's depicted in this image here. And when you have posterior medial comminution, it can make it much harder for you to get fixation, and it has much higher risk of hardware failure. And then also what we call is this lateral wall thickness. And so when you don't have enough lateral wall thickness, what you can see is that that also can lead to more increased hardware fixation failure. So another commonly asked classification has to do with periprosthetic fractures, in particular of the hip. And so that's where the Vancouver classification comes in. So Vancouver type A is affecting either the lesser and or greater trochanters. Most of the time in these scenarios, these are often stable, meaning that oftentimes the total hip or, hemiarthroplasty components are oftentimes in stable position. But sometimes you do need to consider some sort of fixation for things like the greater trochanter to help, make sure that you have enough strength with your abductors, etc. Then we move on to your Vancouver B. And within Vancouver B, you have three different types. So in Vancouver B1, this is where the fracture is where the implant is. However, this implant itself is stable. So oftentimes in these scenarios, you can put things like cables. Sometimes you can consider putting in plates and screws, although that can be very challenging to basically navigate screws around your, total hip or hemiarthroplasty that you already have in. Versus your type B2, this is where you have a loose implant. And once again, this is where you have that fracture that's going where you have the prosthesis, but now you have a loose implant. And typically in these scenarios, that's where you have to either do like a exchange of your hemiarthroplasty or total hip arthroplasty with like a longer stem. And so that gets into a lot of weeds of different options. But the point being is that in B2, it's unstable. So you can't just throw a cable around it and call it good, meaning that this implant is loose, whether it's in the metaphyseal region or, for example, in B3, where now it's loose more distally. So you also have that loss of fixation in the diaphysis. And oftentimes in B3, you'll have very poor bone stock. And then in Vancouver C, this is where you have a fracture distal to the stem. This is typically in areas where you have what we call like a stress riser. And so in those scenarios, oftentimes you can consider things like plate and screw fixation. You can also consider things like revision arthroplasty. But this classification is one that is very important to us when we're thinking about what type of implants or type of fixation might we need, or is this something we could even potentially treat non-operatively? So when it comes to acetabulum, there are different classifications, but I think one of the most important things is trying to understand what we call Judet views. And so with Judet views, this is a way for us to basically assess looking at anterior column, anterior wall, posterior wall. And sometimes it can be a little overwhelming with trying to remember, well, which view does which? And so I really like this image here that's also from the Pocket Pimped videos. And this is helping demonstrate what's in each view. So the way I like to remember is Iowa, meaning iliac oblique wall anterior. So Iowa. And what that does is if I remember that the anterior wall is with the iliac oblique, then I know that posterior column is with the iliac oblique. And so in this image here, what you can see is that the iliac crest or the ilium is basically the biggest thing in view here. And so this is your iliac oblique. And what you can see is this anterior wall and then your posterior column are the best things you see on this view. Now, when we contrast that to your obturator or oblique, this is now where, notice how the ilium no longer looks as big. Now the obturator looks much bigger. In this scenario, what we can see much better is the posterior wall and the anterior column. So if you remember Iowa, iliac oblique, wall anterior, then you can remember, well, anterior wall means posterior column, iliac oblique. And then the opposite is for your obturator oblique. This is another great image that I love for pocket pimped. A common thing you might be asked about is, especially when you're asked at fracture conference to read an X-ray, is to mark out your landmarks or to read your different landmark lines. And so here we have our iliopectineal line, which is marking out our anterior column. We have our ilioischial line, marking out our posterior column. We have our anterior wall, posterior wall. These can sometimes be hard to differentiate, but they can be very helpful when we're getting into the nuances of assessing things like anaversion. We also have here what we call our teardrop, and this can be very helpful when we're looking at assessing like total hip or placement of like our acetabular component, making sure that the inferior aspect's at the bottom of the teardrop. And then here we have the dome or the sourceal. And so this is something that is oftentimes disrupted in different acetabular fractures. And now also with pelvis fractures is sometimes it can be confusing about remembering the outlet versus the inlet view. And so in this image here, you can see for the outlet view, basically you can see more of the obturators in the view here versus in your inlet view. Now you're angling down, so you're looking into the pelvis. And so that when you're looking into the pelvis, you don't see your big obturators. Instead, you're seeing basically the hole where all your pelvic organs are. And so that's how an easier way to remember the inlet views are looking into the pelvis. You need space to see inside the pelvis versus your outlet view is you're no longer seeing, the big opening for where all your abdominal organs are. Another commonly asked classification has to do with the tibial plateau, and this is the Schatzker classification. And this is also one that's really important when we're thinking about non-operative versus operative management, and this can play a really big role in how we're assessing, does this patient need something like an external fixator? That would be something, for example, in our type 6, which I'll talk about in a second, versus is this one that's a non-displaced type 1, meaning a lateral split in a geriatric low ambulatory patient? Maybe that's one you could do non-operative management. And so with the classification, the first one is you get a lateral split. Type 2 is you get a lateral split and depression. Type 3 is you just have this depression of your joint line. Type 4 is now you have a fracture of your medial plateau. And in general, your medial plateau, whenever you have a fracture there, those are typically almost always going to get operative intervention. Now, there's obviously going to be nuances depending on your patient, risk factors, et cetera. But in general, most of the time, whenever you have the medial side of the plateau affected, most of the time that's going to be an indication for some sort of operative intervention. Moving on from there, we have bicondylar, which is type 5, meaning you're affecting both the medial and the lateral. And then type 6, this is arguably the worst. And this is where you have not only fracture typically of your medial and lateral, but you have this metadiaphyseal separation. So this makes it far more unstable. And the reason why this is so important is because typically when you see a tibial plateau fracture, oftentimes it's from a high energy mechanism, especially when you see a 4, 5, or 6. So that means that those patients are typically going to have much more soft tissue swelling. They're typically going to have a much higher risk for any sort of like wound complications, particularly if they get surgery acutely. Now, sometimes soft tissue swelling isn't a big deal and you can fix these acutely, but oftentimes when you see 4, 5, and 6 for the Schatzker classification, most orthopedic surgeons will do like an external fixator, except for in kind of the patients where they have really good soft tissue swelling. In addition with these, it's important to consider what we call like a knee dislocation, meaning that the knee is so unstable that oftentimes when we see things like a type 5 or type 6, we almost consider it like they had a knee dislocation or it's so unstable that we need to put on external fixator. We need to put on some sort of stabilizing intervention acutely because their knee essentially is unable to maintain, normal congruency. And so these are patients where they're going to be a much higher risk of things like compartment syndrome, and certainly a much higher risk of other vascular complications. So one of the things that you can do that's very helpful as a medical student is if you're helping with rounding on these patients or seeing these patients in the emergency room, is getting these legs elevated as much as possible, helping reduce soft tissue swelling. Obviously, make sure you're checking in with your resident before you're, doing anything, but that's something that can be very helpful. And especially if you're checking in on patients on the floor and helping out the intern, making sure that these extremities are elevated can really help with reducing soft tissue swelling. So with ankle fractures, one that's commonly asked is related to what we call the Weber classification. And this is looking at the distal fibula. And the reason why this is important is because it helps us assess, is the injury likely affecting the syndesmosis or not? And that has a lot to do with what can likely be treated non-operatively versus things that likely might need operative fixation or syndesmotic fixation. So with your Weber A, these are fractures that are below the syndesmosis. Versus type B, these are fractures at the level of the syndesmosis. And type C, these are above the level of the syndesmosis. So typically, if you have kind of like an avulsion fracture of the distal fibula, so like a Weber A lot of these you can potentially consider non-operative management versus ones where they're comminuted or they're affecting the syndesmosis, oftentimes in like Weber Bs, those are ones that typically are indicative of operative interventions. Now, of course, you're going to be reading about, this is a golden answers operative intervention or not operative treatment, but always keep in mind there are so many different nuances. Does the patient have uncontrolled diabetes? I can't tell you how many patients come in, we check their hemoglobin A1C and it's 11, or they have peripheral vascular disease and they already have a diabetic ulcer. Those are all important things to consider when you're considering operative versus non-operative management. And this talk is not going to be focusing on a lot of those nuances, but I think that's something just always to keep in mind, again, with that humility and teachability as a medical student, is just because you memorize all these classifications or maybe even have them better memorized than the resident you're working with, that doesn't mean that you necessarily know the operative or non-operative indications any better. And it's really important to always take a step back and recognize these classifications help us with giving us a framework for what's non-operative versus operative or what type of fixation we want to put in. But there are so many other patient-specific considerations when we're thinking about how we're going to be handling different types of fractures. So another type of classification is the Langhausen classification. And so this is one where you might be asked just by looking at an X-ray, what type of Langhausen classification is this? Is it supination, external rotation, supination, adduction, etc.? And the way I try to keep this straight is if you like right now with your ankle, basically practice. So for example, put your ankle into supination motion and then externally rotate. When you do that, what you'll notice with your supination external rotation is that you basically initially have a force that goes up to your medial malleolus, that's your supination, and then your external rotation is you get this twisting motion that now goes over to the fibula forces. So in your supination external rotation, you get this basically kind of transverse-ish fracture of the medial malleolus, and then this oblique fracture of the distal fibula or the lateral malleolus. Why? Because once again, you start with supination to have that force on the medial malleolus, and now you twist into external rotation, and that provides that force of energy into this oblique fracture to the lateral malleolus. Now let's contrast that with supination adduction. So in supination, we have the initial force on that medial malleolus. Now with adduction, now imagine you're basically cranking it even more into that supination adduction. So now you're putting all this extra force into that medial malleolus, and that causes this oblique shear force. So supination and then adduction, you're putting even more of this torque on that medial malleolus, and then that results in this oblique fracture to the medial malleolus. Versus now, if you imagine, put your foot into pronation, and now with pronation, you're going to be having this initial force that's kind of more on the lateral malleolus. And now with external rotation, now you're getting this twisting motion that's now going to be affecting more like your Weber C. So now you're going to be affecting more of your distal fibula. And so with that, you're going to be getting this more like transverse fracture to your medial malleolus. Now your force is basically, it's almost like a chip off your medial malleolus, and all that force is going over to your lateral side. Now imagine you're in pronation, and now with the abduction, now you're basically providing that compression force. And so now that's why with pronation and abduction, now that's typically where you start to see this like shear fragment or a bunch of comminution on your distal fibula, because you're basically putting all this force and it's going right up into the lateral malleolus slash distal fibula. So I know that that can be kind of a lot to put your head around, but I always, with like these types of questions, is I'll literally like move my ankle when I'm like seeing the x-ray, and I think about how that force is, and that typically helps clue me into what the X-ray looks like. And then another commonly asked, thing you might get is related to distal radius fractures. And most of the time with this, it has to do with understanding radial inclination, radial height, and then this volar or palmar tilt. And so the simple way to kind of memorize it is if you remember like 11, 11, 22, 11 plus 11 equals 22. So 11, meaning your volar tilt is typically about 11 degrees. Radial height is typically around 11 degrees. And then your radial inclination is oftentimes around 22 to 23 degrees. That's how I remember it is 11, 11, and then you get 22. And this is really important when we're doing operative intervention for like a distal radius fracture, assessing whether or not there is appropriate radial inclination, volar tilt. All of that, if you don't have it in appropriate alignment, can increase the risk for things like non-union or chronic arthritis. And so with your distal radius fractures, there's a bunch of different terms that can be utilized. One of the most common ones that you're going to be seeing is what we call a Colles fracture, meaning dorsally displaced. And so if you think about it, so dorsally displaced, meaning that it's going dorsal, versus a Smith is where you see it's volarly displaced. A Barton fracture is, think about it more like a shear fracture. So that's what you can see here. A chauffeur fracture is just where it's affecting like the radial styloid. And then a die punch fracture is what we have depicted here, which is where you basically have this compression into the lunate. And so this can cause basically the depression of the articular surface. And so this is one where, similar to like a tibial plateau where you get that incongruity of the joint surface, is now you basically have to re-elevate that joint surface. And so out of all of these, the one you'll most likely be asked is about, Colles, so you're dorsally displaced. That's one of the most common ones that most patients have when they've, have a foosh or fall on outstretched hand injury. Volar Barton, this kind of shear fragment, and that's one typically where you're going to put some sort of volar buttress plate to help basically push this fragment back up and realign that joint surface. And then more rarely you'll see things like the chauffeur or the die punch or the Smith. So once again, your goal as a medical student is, if you can memorize these names, great, but that's not the expectation. Focus on the anatomy. All these classifications and things I'm discussing, these are bonus points, but at the end of the day, these are the expectations of us as residents. And as a medical student, even if you know all of these, but act unprofessionally, you're not doing yourself any service. And so lastly, I just want to quickly highlight pediatric fractures. And so the most common classification with pediatrics is knowing your Salter-Harris classification. And so with the Salter-Harris, this is basically type 1 is through the growth plate. So S, you can think like separated. Oftentimes your type 1s, you can't actually see them on X-ray. Most of the time, the only way you can tell is if the patient says, I have like pain, and where they localize pain is right over the physis, or you get things like an MRI. But typically type 1s are often ones that are more like clinical diagnoses. Versus type 2, this is where it goes into the metaphysis. So the way I remember that is type 2 is metaphyseal. So type 2 is above the growth plate versus type 3 is below the growth plate. Type 4 is where it goes through the growth plate. And then type 5 is, we call this like your erosion. So it's basically where you're getting this like axial force, and that's one of the most destructive ones to your growth plate itself. So if you can remember Salter-Harris, that's going to be one of the most commonly asked ones when it comes to pediatric fractures. And when it comes to the most common pediatric fracture, supracondylar humerus is probably, without question, the most common one. Distal radius fractures in kids are also very common. But with their supracondylar humerus fracture, we have what we call the Gartland classification. And so essentially what this is it's basically looking at the lateral view of the elbow. And this helps us assess whether or not surgery is likely needed. So for Gartland's type 1, this is where you have no displacement of this distal humerus. These are typically ones that we put into a long arm cast for about 3 to 4 weeks and then let the kids fly free. Gartland type 2 is where there is some angulation, but it's intact posteriorly, meaning that it basically has a hinge posteriorly. So it opens up anteriorly, but it has this intact hinge posteriorly. versus type 3 is where you have complete displacement. But as you can see in this image here, the periosteum in kids is super thick. So you still have the periosteum that's intact posteriorly. So these are unstable. Now, type 4, these are ones that are typically an intraoperative diagnosis. And these are ones where you have complete periosteal disruption and instability. And so these are ones that are going to be off not only in your like coronal or sagittal views, but also rotationally. And so when you have supracondylar humerus fractures, there's also ones that are like an extension, meaning here where we can see that the distal aspect is an extension versus there are ones where they're in flexion, where this distal aspect is basically up in the front. And so those are ones that are going to be more unstable or your flexion ones. Again, you don't need to know all of the different nuances, but the point being is that the Gartland is one of the most commonly used ones for supracondylar humerus because it affects our management, which kids we're taking to surgery for a closed reduction versus cutaneous pinning versus ones that might potentially actually need to be opened in order for us to get a good reduction. And then I wanted to just quickly highlight about open fractures. So the Gasteel-Anderson classification, I think this is one of the most commonly asked questions for medical students, and this has to do with the type of open fracture injury. So what we can see here is that in type 1, this is typically a lower energy mechanism, not always, and oftentimes the wound size, we consider it if it's under 1 centimeter, and with that, we often consider this to be low soft tissue injury, not a lot of contamination. Versus when we get up to a type 2, that's typically going to be greater than 1 centimeter wound size, but under 10 centimeters. And this is where you start to see a lot more soft tissue injury. And you also see a little bit more contamination, or at least a higher risk of that. Now we get into our type 3s. And within our type 3s, we have type A, B, and C. In your type 3s, these are typically wounds that are greater than 10 centimeters. And these are ones that are going to have much more soft tissue injury, much more contamination. Now, an important caveat to this is when you have things like a femur fracture, even if it's a little poke hole, so it's under 1 centimeter, we still consider femur fractures with a poke hole wound to be type 3s. The reason is because it's such a high energy mechanism for that femur to go all the way through all of your all those muscles and fascia that it's considered to be, extensive soft tissue injury, so we automatically consider a type 3. Now, within the type 3, the type A is typically where you can close that wound primarily, or you need some sort of like simple soft tissue coverage and there's no vascular injury. Versus type B, this is where you need plastic surgery involved, such as a free flap or other soft tissue augmentation. Type 3 are those where you need some sort of vascular repair. And this is super important. In particular, let's say you have an open fracture where you have a vascular injury or even a closed fracture with a vascular injury. One of the most important things is you as an orthopedic surgeon are coming in and you're typically putting on things like an external fixator and holding things out to length. Because imagine if the vascular surgeon or general surgeon comes in, they fix the vasculature, but it's not out to length. And now you put it out to length. Well, now you just destroyed the vascular repair. And so that's something where you might, for example, like as a medical student or as a resident, be coming in overnight to put on things like an X-fix to temporize because the patient has some sort of vascular injury. And then compartment syndrome. You're going to be asked about compartment syndrome. You're going to be asked about the 6Ps, the paresthesia, pallor, pulselessness, poikilothermia, paralysis, pain out of proportion exam. But in real life, most of the time with compartment syndrome, this is something where it's a clinical diagnosis and oftentimes it is pain out of proportion. One of the things that can be really helpful when you're assessing for compartment syndrome is if you stretch whatever, compartment. So if it's the leg, you're putting into dorsiflexion and plantar flexion, and they get worse pain with dorsiflexion. Oftentimes you can physically feel the compartments and they feel hard. Now, if you're getting to the point where now the patient already is losing sensation, they're losing blood flow, typically it's already too late at that point. And so that's why compartment syndrome is something where we always are worried about in the back of our mind. And in scenarios where we have, a patient that is intubated or one that's an unreliable patient, they're intoxicated, or one where we're just not too sure if our clinical exam is exactly correct. We do have things where you can measure compartments. And typically within that, you're going to measure the compartment pressure within 5 millimeters of fracture site and try to do at least 4 readings to get an average. But typically compartment syndrome, it's a clinical diagnosis, and that's just something that over time you start to build up with. All right, so now I know I've talked about a lot of things, but I want to just kind of close things off with talking about some resources and some summary key points. So here are some screenshots of some of my favorite resources that I started using as a medical student and still use as a medical student or still use as a resident. So the Pocket Pimped book, that one is very helpful. They have a lot of pimp questions. I always had that in my pocket. And before a case, like for example, if it was an ACL or if you're going in to do a total hip, I would just quickly peruse and try to look at what are those questions because you'll likely be asked those. It's very reliable. Nailed It Ortho is a great podcast. I listen to it on a lot of my longer drives. It's a really good resource. They also have videos on YouTube and they have a good website, so I highly recommend them. Dr. Wendell Cole, who founded it, he also made a book that I also bought that on Amazon and I've used that for my board studying as a resident, where it's just kind of like simple, tricks and tips, and it's in a very like quick kind of bullet point way. AO here is for like AO trauma. This is something I use still all the time as a resident, like quickly on my phone to refresh on an approach. It's really nice visuals for when you're doing different approaches. What are the vascular or neurologic structures that you're keeping an eye out for? Handbook of Fractures, that's kind of one of the classic books where it kind of gives you the bread and butter of various different types of fractures, what things can be treated non-operatively versus things that are treated operatively. Highly recommend that. In addition to this Netter's Concise Orthopedic Anatomy, I use this book a lot, and they just do a really good job of keeping things simple with what are the key takeaways for the anatomy in different regions of the body. Some other great resources is this hip and knee book. This is free and it's online. And I actually was reviewing it this past week before some arthroplasty cases. And it goes over like the fundamentals of arthroplasty in a really specific, direct way that's very user friendly. So I highly recommend using that. Nail Fracture Conference, we've done some collaborations with them through OrthoLink Scholars, and they've done a really good job of providing resources to medical students to help prepare you for common things that you might see for different fractures at Fracture Conference and how to prepare for reading those x-rays. So highly recommend them. And then Ortho Bullets. This is a great resource for just getting the quick and dirty for different types of fractures or procedures. As a resident, that's something I use as well for, getting questions. So all of these are wonderful resources. Now, there are tons more out there. And one of the things that can be really easy to do is to get so overwhelmed because you're using 15 different resources. What I recommend is starting with a few. So, for example, what I did is I had Netter's Concise Anatomy and I had Pocket Pimped, and then I used Ortho Bullets. And just with those three, that gives you a ton of coverage with the basics and what you need to know. And then with time, I started to add on other resources. What you don't want to do is purchase a ton of textbooks and then never actually get to reading any of them because it's just too overwhelming. You don't have the time. So these are great resources. There are plenty more out there. And what I did was I created this resources document, which will include a link here for you guys to utilize. And I basically just put hyperlinks to the resources that I had listed on the previous slide and some other ones that I have found really helpful throughout the years. Some of them are things that I still use to this day. So once again, there's tons of resources. Try not to overwhelm yourselves and really find 2 to 3 and stick with those and build on them with time. But what you don't want to do is you don't want to start an audition rotation, have 5 different textbooks, and then you don't even read things or really absorb things well because you're so stuck with way too many resources. So the final thoughts, I appreciate y'all being bearing with me. I was trying to cover the most high yield information and I realized there is just way too much I could possibly talk about. So I really wanted to focus on what's the most important things. So one of the key aspects, once again, is communicating with your intern and residents about expectations and making sure that you're professional. One of the things that I always tell people is learn to read the room. let's say you're in the middle of a case and all of a sudden the attending says, "Hey, turn the music down." That's a cue and like something's not going right. Make sure that you're not just socializing and you're being too, friendly without also making sure you're maintaining that professionalism. It's good to showcase who you are. If someone asks you about your family or where you're from, great, answer those questions. But what you don't want to do is you don't want to come across as someone who's so laissez-faire. They're just, so casual that they don't have this sense of like, I understand the dynamics, I understand where I am in the totem pole. And you want to make sure that you maintain that and you want to maintain that really good communication with residents. So for example, if I'm texting a medical student, I fully expect that they are liking my message or they text back to me, agreed, yes, or they do something to acknowledge that. Just basic things to demonstrate that you are, keeping up with communication. And that's where things like doing group messages with your fellow med students that are on that service with the intern can be really helpful. And ultimately, if you just ask the intern, how would you like to be communicated? How can we help you with dressing changes? What are the expectations? All of that can be really beneficial. With that, think about housing with residents. The downside is you got to be on because just because you're staying with the resident does not mean you can now be messy and, listening to rap music with swear words. Like, just always be cognizant of that. Like, even if the residents are swearing in the resident lounge, or maybe even if the residents are acting unprofessional, that doesn't mean that you should do those things too. Always kind of maintain that like air of like, I'm going to be kind, I'm going to be friendly, but I also am keeping in mind, like, I'm a guest here, I'm here to learn, and I want them to see me as someone that can be a really good, respectful colleague. And so, importantly, with that, it's showcasing your teachability and eagerness to learn. I still don't know all the answers. I get asked questions I don't know the answers to, even when I prepare for cases. That's going to happen. As a medical student, I got asked so many questions I didn't know the answer to. But one of the big positive feedbacks that I got consistently was I was teachable and I was constantly eager to learn and say, oh, I didn't know that, but let me go read more about that. And I'd come back the next day and I'd say, here's what I read about this. What do you think about that? And so that's a way that you can maintain showing that teachability and maintaining that you're showing that eagerness to learn versus something that's really frustrating is when you ask them a question, they say, I don't know. And then they just go silent. A way where, let's say they ask you a question, you don't know the answer, you say, take a breath. First off, take a breath. Say, I don't know the answer to that, but I do know about this, and this, or something that might be related to that topic, and say, is that related to this? And you can try think of like articulate questions. And what you want to make sure you do is you don't just ask a bunch of questions. Make sure that if you're asking a question, it's thoughtful. You're making sure you're asking a question that isn't something you can quickly look up on Ortho bullets. And so the more that you do that, the more that it shows you're really engaged and you're trying to learn and you're not just regurgitating, facts. You're not just repeating the same questions over and over to try look good. Again, focus on anatomy. And then importantly, being helpful to other medical students. When I see medical students that are helping each other out, that make changes to the call schedule to help out other med students, that really is something that stands out, especially in my program, because we are such a team-based program. So making sure that you're doing those things, showing initiative, volunteering to do dressing changes, getting the splint materials ready for the resident, that can make a huge impact, make the life for the resident so much easier if you already have the splint cart ready and everything's ready to go for a sugar tongue splint, for example. And let's say you show up on day one, you've never done a sugar tongue splint. It's okay, look it up. And you can always ask the resident for feedback and saying, I haven't done this splint before. Would you mind showing me how you like it done? I would much rather have that versus the medical student who quickly reads about it and then acts arrogant and pretends like they know things and they do it wrong. When reading x-rays, read them concisely, take a breath, leave space for them to ask you follow-up questions. And remember, with reading x-rays, one of the worst things you can do is just ramble on and on and on. There's always more things that could be asked about an x-ray. And if you can say things in a concise way, that's going to help you stand out. Make sure you don't complain, stay late, be present, showcase that enthusiasm. Remembering that when you don't know an answer, it's okay to feel that internal panic inside. We all feel that. But knowing that you did your best to prepare and you're going to take what you didn't know and learn from it and then show up even more prepared the next day. Making sure you own your mistakes. One of the things I did on my audition, I still don't know how this happened because I never sleep through an alarm, is I somehow slept through an alarm. And the resident, he had texted me about coming in. I did not hear it. And in the morning, I full on panicked. I texted him. I was like, I'm so sorry. Is there anything I can do to make it up? And then I went to the chiefs and I told the chiefs, hey, I actually slept in with this resident. I'm so sorry. Please let me know if you want me to take an extra call shift, etc. And the chiefs ended up saying like how much they appreciated that I took full ownership of that moment. Because I remember thinking like, oh my gosh, I'm never going to get an interview because I made this mistake. So take things when you do make a mistake or something like that, and just take full ownership of it, and just move forward and showcase that you are professional. Seeking out feedback is very helpful. When it comes to writing thank you notes, you certainly can. Like us residents, I mean, I love getting a thank you note, but at the same time, don't feel obligated to getting a thank you note. And especially if you're just going to write thank you notes to all the faculty that you didn't even work with, it's honestly probably not going to make a difference in you getting an interview or not. And then ultimately, the most important takeaway out of all this is ortho is a very small world. You never know who knows who and the impact they might have. So if you make a bad impression with one resident, they're probably friends with residents at another program, and residents, attendings, they talk. So make sure that you are always showcasing your best self. We're all going to make mistakes. Showcase that you're a professional, showcase that you are kind, showcase that you're a team player, and the rest will fall into place. The medical students, like I said, that we typically don't allow interviews with, that audition with us, are those that are arrogant, those that do not work well on the team, those that don't work well with other medical students, and those that basically are kind of like a fly on the wall. They don't do anything to demonstrate that they're able to engage in those soft skills, and they don't demonstrate that they can work well within our program's culture. Each program is going to have a different culture, they're going to have different expectations, but most importantly, if you are maintaining that compassion, that preparedness, and that professionalism, you're going to be able to do well at almost any program you go to. So, with that, I know I went over time and I really appreciate all of you who remained on this call. I'm happy to answer some questions. And if you're interested in more webinars on, maybe more focused topics, please feel free to let us know. I'm happy to do so. Again, my goal is to help give you the advice that no one gave to me to make you feel more prepared and help you on your journey, because it's really challenging. Like I said, I just finished my fellowship audition rotation and it went really well. And all the principles I talked about in here are the same things that I did now auditioning for fellowship. And if you stick to those core principles, it's going to serve you well, not only on your auditions, but when you're a resident and then ultimately applying for fellowships and then career jobs.